Very good morning, everyone. I am presenting two abstracts. Both are in HER2 positive brain metastasis. One is a TKI and the other one is an ADC. So this is the Institute Narayana Health in Shimoga where I work. So the first abstract is brain radiotherapy with pyrotinib and capecitabine in patients with HER2 positive breast cancer and brain metastasis. So it's a non-randomized phase 2 trial. So half of my work is actually helped out by Dr. Chandrakant who spoke about pyrotinib. So he also made a racist comment that it is a Chinese TKI. So he also explained to us the difference between pyrotinib and lapatinib. So if you have missed out his comment because of a heavy breakfast, I would like to tell you again that the difference between pyrotinib and lapatinib is that whereas lapatinib is a reversible HER2 TKI, pyrotinib is irreversible. And whereas lapatinib is only HER2 and HER1, which is EGFR, this is a pan-HER inhibitor. Pyrotinib inhibits not only HER2, 1 but also 4. So this was done in China and it was published in JAMA Oncology in 2024. So let's understand what was the research question. Can the combination of CNS radiotherapy concurrently with pyrotinib and capecitabine can improve the CNS progression-free survival in patients with HER2 positive breast cancer with brain metastasis? So this combination of pyrotinib and capecitabine is reminiscent of lapatinib capecitabine, which we used to give for CNS metastasis in HER2 positive breast cancer. So let's see the design, setting and the participants. So it was a single arm, single center phase 2 non-randomized clinical trial. So it was done for 2 years. It was recruited by a the radiation oncology department of this center. So the intervention was that all the patients with CNS metastasis, they either received fractionated stereotactic radiotherapy, SBRT, or whole brain radiotherapy depending on the number of brain mets. So if it was less than 4, they received SBRT, otherwise they received whole brain RT. The treatment was pyrotinib 400 mg once a day with capecitabine 1000 milligram per meter square twice a day. And from day 1 to day 14 in a 3-week cycle, and most of the patients, they started on day 1 of radiotherapy and they continued after completion of radiotherapy also, they continued with pyrotinib and capecitabine maintenance. So the main outcome was primary endpoint of 1 year CNS PFS. Secondary endpoints were overall response rate, PFS, OS, safety, and changes in the neurocognitive function as documented by the mini-mental status examination. So the results were a total of 40 patients were enrolled. The median age was 50.5 years. The median follow-up of 17.3 months. And the 1 year CNS progression-free survival was 74%. And the median CNS progression-free survival was 18 months. And the 1 year PFS was 66.9% and the median progression-free survival was 17.6 months, which is actually good. So the CNS overall response rate was 85%, which is also very good. And most of the patients, they got partial response and the CR rates were lesser compared to the PR rates. And the median overall survival is not yet reached. So these are the Kaplan-Meier curves where the CNS PFS is to the tune of 17 to 18 months and the PFS is around 17.5 months. And if we see the response rates, the majority of patients, they received PR and many had CNS CR also. So the safety, as Dr. Chandrakant also mentioned, that the diarrhea was very troublesome and one patient had acute tubular necrosis because of severe dehydration also. So the most common grade 3, grade 4 treatment related adverse event was diarrhea. And the radiation necrosis which happens was not very high. It was around 6% in patients with SBRT. And most of the patients, they maintained a good neurocognitive function. So this concurs with another trial with pyrotinib, the Permeate study, which used pyrotinib and capecitabine in patients who were radiotherapy naive. So the CNS overall response rates were around 74%, median PFS was 11 months. So the limitations are that it is a single arm, single center, small sample size, selection bias may limit the generalizability. I haven't used pyrotinib, but the study says it's good for patients with brain metastasis. So we have to still procure the medicine and use it for ourselves. So let's move on to the next one, which is TDXD in patients with HER2 positive advanced metastatic breast cancer in patients with and without brain metastasis. Destiny Breast 12, the primary results were presented in ESMO 2024. So TDXD, whenever a monoclonal comes, we are always asking this question, does it cross the blood-brain barrier? Does it work in patients with brain mets? So TDXD is an ADC, and small studies have always shown good benefit in patients with brain metastasis. But this is a phase 3 multi-center open label study. This is the largest prospective study of TDXD in patients with brain metastasis. So the patients had less than 2 prior lines of therapy. So there were 2 cohorts. There is no comparator arm. There are patients with brain metastasis and patients without brain metastasis. Both of them received TDXD 5.4 mg per kg every 3 weekly. And the results were, the primary endpoint was PFS, and other endpoints were CNS PFS, overall response rate, CNS response rates. So the most of the patients, they continued on TDXD, and 10% had adverse events in both the populations, with brain mets and without brain mets. So the many patients were previously exposed to trastuzumab, pertuzumab, and even TDM1. So they also had extracranial metastasis like liver mets, lung mets. So this is the patients with baseline brain metastasis. So in patients who had brain metastasis, the median PFS was 17.3 months, and the 12 months PFS percentage was 61%. And they also saw whether the patients had stable brain mets or active brain mets with neurological symptoms. So in both the groups, whether the patient had just incidentally detected brain mets or actively neurologically symptomatic brain mets, it was having a 12 months PFS of 62 to 59.6%. And in patients who had brain mets, the CNS PFS was, the 12 months CNS PFS was 58.9%, which is very good for patients with brain mets. So the overall response rates were to the tune of 49% in stable brain mets and 54% in active brain mets. And so the CR rates were to the tune of 4%, and mostly patients got partial responses. So the CNS overall response rates were in all patients it was around 71%, and in active brain mets it was 62%. So in patients who had no baseline brain metastasis, those with only extracranial disease also, the overall response rates were to the tune of 62%. So the overall survival in patients with and without brain metastasis, it's very interesting that whether they had brain mets or not, the 12 months overall survival was 90% in both patients with or without brain metastasis. So the adverse events were similar to what we have seen in the earlier trials. There was neutropenia, alopecia, and ILD also. So to conclude, this is a prospective phase 3B4 study where it was shown that TDXD is showing a consistent benefit in patients with or without brain metastasis, with a 12-month PFS of 61% and CNS overall response rates of 71%. So the safety profile is similar, and 12-month overall survival was maintained in patient with or without brain metastasis to the tune of 90%. So the results support the use of TDXD in patients with brain metastasis irrespective of whether they had stable brain mets or neurologically symptomatic brain mets. So I'm yet to use TDXD in a patient with brain metastasis, but I'm very enthusiastic and very optimistic for such patients because we don't have pyrotinib, we are not happy with lapatinib capecitabine. TDXD is available in India, so I'm very enthusiastic. Thank you so much.